Journal Club from APTA Connecticut. We are happy to welcome Cristina Colon-Semenza. She's going to talk about an article that she's chosen for today's Journal Club. If you guys do have any questions or comments, just make sure that you put them in the chat box. We will be fielding questions and comments throughout the chat. And then we'll just save any discussion for the end, unless Cristina opens it up during any part of the discussion today. So I'm going to turn it over to Cristina.
Yes, thank you, Steph, and thank you so much for joining us here tonight. So as Steph indicated, my name is Cristina Colon-Semenza. I'm a physical therapist and research scientist at Boston University's Center for Neurorehabilitation. And I will be transitioning to faculty at the University of Connecticut in their Doctor of Physical Therapy program in the fall. And I'm excited to discuss with you all this article, a scoping review of the prevalence of neurologic comorbidities in patients hospitalized for COVID-19 by Herman et al. And so, Steph, you can go ahead and advance it, please. And so before we get into the meat of our Journal Club discussion today, I just wanted to make a plug for the APTA-CT's Neurologic Special Interest Group, of which I am a co-chair of. And we are a fairly new SIG, and we'd love to have your energy, your questions, your interest and participation. So please do reach out to us. You can email us or find us on social media, but we would love to know what other things you would like to do to meet your needs as a therapist that maybe is interested in neurologic physical therapy. So from there, we'll move on to our next slide and our objectives for tonight. I'm just going to give a very brief overview of COVID-19. I by no means am an expert on COVID-19. I'm learning right along with all the rest of you. And in fact, I recently completed my PhD, and I've been working in a research lab and have not had the opportunity to work clinically with any individuals with COVID-19. So I actually have had some outreach to some therapists, some colleagues that have had experience, and I'm going to be bringing in their perspectives into this discussion. But if you are one of those therapists that are on the front lines and have had experiences and perspectives, I am going to ask you throughout the discussion to join in and to share your clinical experience and perspective so that we can hopefully digest this material and make it clinically applicable and relevant. So I'm going to give an overview of the article. I have discussion questions interspersed throughout, and we will bring it to clinical relevance. And Steph, you can go ahead and advance there. I have my little thinking guy there, so I've interspersed these throughout to remind me to take a pause to allow you all to ask questions in the moment. I know sometimes when I'm having presentations, I don't want to wait to the end. I want to get my question answered then. So hopefully this can be informal and we can have a really robust discussion with questions interspersed. But please do also use the chat. So COVID-19. So here we are in the midst of this pandemic, and this is obviously not something that we learned about in PT school and that no one is prepared for. But what we have come to understand, and Steph, you can go ahead and advance 3 times, is that the typical presentation is the high fever, flu-like symptoms, especially a cough, especially with difficulty breathing, affecting the lungs, and acute respiratory distress syndrome. And Steph, go ahead and advance it once more. What we seem to have less information about, especially in the popular media and popular culture, is the effect of this virus on the neurologic system, whether it's comorbidities that exist prior to, or how the disease itself then causes harm to the neurologic system. So Steph, you can go ahead and advance it. So that brings us to the article that we are going to discuss today. And so I chose this article to try and understand. I am a neurologic clinical specialist with the APTA, and that is my area of interest and expertise. And I'm really wanting to know how coronavirus will affect my patients that are living with neurological disorders, or what to expect in individuals who will be coming to the clinic should we be looking out for certain presentations? So this article that we're discussing today is a scoping review of the prevalence of neurologic comorbidities in patients hospitalized for COVID-19. And Steph, I'll have you advance it twice, please. And so there is our timeline here. So it's looking at the prevalence of neurologic comorbidities before the onset of COVID, but then also the title is a little bit misleading because what they also are doing is they're looking at the incidence of new neurological events in patients hospitalized with COVID. And you can go ahead and advance it, Steph. And so I just wanted to pause a moment and bring us back to what they're actually doing in this journal article, because I know that I am very familiar with the systematic review, but the scoping review is something newer, less familiar. And so I just wanted to share with you all the differences. So Sam et al. In this article, which is a scoping review of scoping reviews, really lays out the difference between the two. So while a systematic review, the one we're all familiar with, its purpose is to gather evidence from a smaller number of studies, a relatively smaller number of studies, and it's pertained to a focused research question. So, a systematic review might be asking the question, is high intensity exercise effective to slow down the course of disease in Parkinson's disease? And they would look at randomized controlled trials that have attempted to answer this question and then synthesize this evidence, but they're also assessing the risk of bias in order to determine how much weight we should put towards these results and conclusions. So a scoping review, what we're looking at tonight, their purpose is very different. This is an overview of a large and diverse body of literature pertaining to this broad topic, right? We're trying to just understand what's going on with COVID-19 in the neurological system. So it's this very broad topic, not this specific research question. And as you noticed in the article, that it's a greater range of study designs and methodologies. It's not just the gold standard RCT that we'll see in the systematic reviews. It's the case studies, case series, retrospective observational analyses. And so it's bringing in a lot of diverse different types of methodologies, and it's giving a descriptive overview without critically appraising the individual studies. So, and Steph, I'll have you advance it one time. Some of the critiques of the scoping review are that individuals will say, well, it's less rigorous and this is just, a quick alternative. And so I would say, I don't know that we should keep these two different types of reviews in a hierarchy. Instead, we just need to realize that they have different purposes. And for right now, in trying to understand what's going on with COVID, a scoping review is the perfect type of review to get at the answers that we need to help us understand what's going on with COVID-19 in the neurological system. But all that to say, I'm hoping that in our discussion and what we take away from this journal article needs to be taken with a grain of salt. So maybe we wouldn't place as much weight in these results because they are not in the gold standard designs. The literature hasn't been assessed for risk of bias. And we'll get to some of this as we're discussing the article about what the implications are. And Steph, you can go ahead and advance it from there. Okay, so what were the methods that they used here to bring together all of this literature for this broad topic? Well, they did a search and they did it in PubMed, Embase, CINAHL. They also used the gray literature, and the gray literature is so it's kind of atypical literature. It's like reports that maybe a hospital would put out, or a dissertation that's not yet published. So it's unpublished material that wouldn't otherwise be accessible in the typical databases like PubMed and such. So the search terms they used were COVID-19 and then neuro, brain, stroke, seizure, and you see the list there, neuropathy, neuromuscular, dementia. And then the inclusion criteria were individuals who were over 18 years of age and diagnosed and received inpatient treatment for COVID-19. And the study had to also report on pre-existing neurocomorbidities or events during the course of illness. And Steph, I'll have you advance it one time. Yep. So these search terms, this inclusion criteria, just is one of those times where it had me going, what might affect these results given these methods? So either enter into the chat or go ahead and unmute yourself if you would be willing to share what you think, maybe what's missing from these search terms, or what you are already kind of putting together as you're looking at these inclusion criteria. Does anything come to mind? Anyone? Don't be shy. So one of the things that I noticed in this list of terms is, and it's probably because of my bias, is that I study Parkinson's disease, and they didn't include Parkinson's disease, Alzheimer's disease, any specific conditions or diagnoses, so that if in a title and an abstract, there were studies that were focused on these conditions, they wouldn't necessarily be included in these results. So that might be some literature that was missed in this search. And then, yeah, so Naga shared nerve root viral conditions. Yeah, and so Naga, tell me if you wouldn't mind in the chat or by unmuting yourself, is there a reason why you are particularly interested in those conditions?
Yeah, I'm thinking about if there is a widespread viral infection, if people are having musculoskeletal problems. I'm also thinking about, is there any viral disease effect to the nerve roots or to the spinal cord?
Yes, so yeah, that's a great point. And that's something that we don't yet know about, that is this virus neurotropic? Is it something that can target our nerve cells particularly? And in this study, they mentioned that we do not yet have that information to know, but that would be enlightening to know. Do we need to be specifically aware of the fact that this virus can attack our nerve cells, our nerve roots, and what is that relationship between this virus? So right, so there's a lot. The point being that it's not an all-inclusive search, so it is kind of scratching at the surface of us understanding the relationship between the virus and the neurologic system. And obviously in this inclusion criteria, they're only looking at adults, so the pediatric population is not included. And also, when looking at this inclusion criteria, we see that it's individuals who are diagnosed and received inpatient treatment for COVID-19, so that those individuals who were maybe came into the hospital, received the diagnosis, but then returned home, they would not be included in this study. And then, of course, the individuals who are just not going to the hospital at all. So again, we're getting a very particular sample, so keep that in mind when we are looking at this study. Okay, so Steph, you can advance it. So they were able to look at 642 articles that were reviewed. Given their inclusion-exclusion criteria, they included 32 articles, and then ultimately they had 22 that were focused upon the comorbidities that pre-existed corona or COVID-19, and then 10 that were focused on the incidence of a new neurologic condition. And they indicate that within these 32 studies, over 4,000 individuals are being assessed or were included, and that the majority of these studies were retrospective, and the majority of the studies that we are considering in this review were from China, since that was our first, the first area that was hit by the virus. And yes, so what did we find from in regards to the pre-existing neurologic conditions? Well, they found that 8% of hospitalized patients diagnosed and treated for COVID-19 had a pre-existing neurologic condition. So not that large of a prevalence, But what I found even more interesting, and Steph, I'll have you advance to the next one, is what seemed to continuously come up was cerebrovascular disease. So cerebrovascular disease was mentioned in several studies, and Steph, I'll have you advance 3 times, please. So in one study, if individuals were treated in an ICU, they were more likely to have cerebrovascular disease. If individuals did not have improvement in their first 10 days of hospitalization, they had a higher incidence of cerebrovascular disease. And then finally, individuals who had COVID that also had underlying cerebrovascular disease were more likely to develop ARDS, or this acute respiratory distress syndrome. And then Steph, I'll have you advance one more time. There was an analysis that was done that looked at individuals with COVID-19 and pneumonia and showed that those who had cerebrovascular disease, this is more predictive of mortality. So cerebrovascular disease is definitely one of those red flags that we know, given this data, likely is indicating increased morbidity and mortality if we're seeing individuals with this underlying condition. And you can go ahead and advance it. So I just want to pause there, and if anyone would be willing to share if these findings are reflective of your clinical experience. Are you finding that it's a small, only about 8% or less than 10% group of individuals who have pre-existing neurologic conditions? And so, yeah, would anyone be willing to share that so far? Be brave. So I guess I'm wondering, is anyone in the group treating individuals with COVID right now? Okay. So in speaking with some colleagues that are in the Boston area that are treating individuals with COVID, she indicated that this is pretty common. The cerebrovascular disease is a common comorbidity, in addition to atherosclerosis, coronary artery disease, peripheral vascular disease. So it seems like there is a trend with, right, all of these vascular issues affecting or being present in individuals that have COVID. And then when you combine that with impaired respiration from the virus, having these ultimately disastrous effects, this is making sense. So yes, so this seems to be reflective of what some of my colleagues are finding in the Boston area that are on COVID units.
I think too, Cristina, sorry to interrupt. I mean, this is a lot of what the literature is coming out and saying as well, that, combination of cerebrovascular disease and excessive blood clotting is something that has been common. And I know in past journal clubs that we've had this and have had more acute care people in the journal clubs have said that they've also commonly seen, like you said, that cerebrovascular disease is something that they're seeing.
Yep. So this does seem to be a frequently reported comorbidity, and it makes sense when we're looking at the effects that we're seeing reported in the literature and even in the media. So Steph, I'll have you go ahead and click one more time. So, and so in looking at these designs and this literature and considering it, another question that came to mind for me is what might be affecting the validity of these findings? So I'm going to throw out my ideas there since we seem to have a quiet group tonight. But one of the things I was wondering is that we're in a unique situation with COVID where individuals are not allowed to have patients, caregivers, family members, loved ones join them in the hospital. And if someone themselves is critically ill, I'm wondering how reliable or how accurate a historian the individual with coronavirus is. so that actually, potentially we are underestimating what might actually be going on in terms of comorbidities if individuals are not able to, or if family members are not there to validate their previous medical history. Additionally, we're in situations where hospitals are maybe short-staffed and maybe getting that medical history isn't of their primary importance. Instead, it's focused on life-saving issues, as has been in a lot of these dire situations in hospitals. So Steph, I'll have you go ahead and advance from there. So in terms of the results with the secondary neurologic complications, this related to these results, they focused mostly on 4 retrospective studies that demonstrated an increase in secondary neurological complications. And then they also shared 6 case studies of secondary neurologic complications. So they, some examples in the case studies were encephalopathy, stroke, hemorrhage, seizures that occurred in an otherwise healthy individual, some pretty massive hemorrhaging, Guillain-Barré. So it was pretty varied in the presentations in the case studies, but the retrospective studies are the ones that we're going to talk about a little bit more. So Steph, I'll have you go ahead and advance to the next one, please. So in a study of 214 patients, 36% had neurological symptoms and complications. And this one I found interesting because they actually included in their definition of neurological symptoms, skeletal muscle pain that was confirmed with elevated creatinine kinase levels. So I thought that that was an interesting presentation, and you can see that that is on the higher end of percentage of neurological events. So, and that was a study out of Wuhan, China. So in this next study in our square, 6% of 221 patients with had an acute cerebrovascular accident. And this was whether it was ischemic or hemorrhagic or thrombosis, they just classified them all within that 6%. So while undergoing treatment for COVID, 6% had an incident, a cerebrovascular event. And then in another study, there's 20% of 274 patients had a hypoxic ischemic encephalopathy. And then finally, that last square there, 65% of 58 patients actually had confusion while in the study and being treated for coronavirus. So you see the numbers are kind of all over the place, and likely that's due to the fact that everyone is defining their neurological events differently. But I will also point out, because that 65% was so high, I wanted to dig a little bit deeper, and this was individuals not only with COVID, but individuals with COVID as well as ARDS, the acute respiratory distress syndrome. So yes. So again, I'm wondering if this is reflective, and I'll have you go ahead and click twice for me, Steph, please. So are these findings reflective of your clinical experiences? Are you all seeing kind of unusual neurological incidents occurring post-COVID? Are you seeing that there's a high incidence of confusion that is occurring in patients that are being treated? Would anyone like to share?
I think
so again,
I think just based off of what we've heard from previous, again, I'm going off of previous journal clubs because I'm not in acute care, but what we've heard in previous journal clubs is that these are definitely common in people who are treating people that are in the hospital for COVID, especially if they end up on a ventilator. So the more severe the patient, or the more involved the patient is, the increased number of comorbidities that they're finding while they're in the hospital. So they are getting more confusion. They are demonstrating significant muscle weakness. They are demonstrating increased risk for cerebrovascular disease. So Based off of what we've been talking about in past journal clubs, it seems like the more severe the patient is affected, then the more severe the complications are.
Yep. Yeah, Steph, that is also what some of my colleagues have shared with me. She was sharing that they routinely do the MOCA with all patients admitted to the COVID unit, and she was reporting, this is just off of the top of her head, but she was feeling like the majority of patients, and she'd estimate about 75%, were scoring, had scores indicating mild cognitive impairment. And these were individuals who did not have cognitive impairments prior to admission. And she was seeing not only were they scoring low on the MOCA, but then functionally she was seeing it with patients having difficulty with motor planning, following commands, problem solving, and demonstrated impaired short-term memory. So that seems to be a consistent finding, both anecdotally as well as in the literature here. Another interesting finding that I thought one of my colleagues shared was that she has been noticing sensory changes and muscular weakness related to peripheral nerve injuries. So not exactly getting at what you're talking about, Naga, with the virus attacking nerve roots, but she's noticing peripheral nerve injuries actually from individuals being in the sustained prone position. So as we come to understand that being in the prone position is helpful in the treatment of COVID-19 because it helps with respiration, puts the lungs in a better advantage to increase oxygen saturation, that individuals were having pressure from being in that one position. She thought that when she first started on the COVID unit and she learned about proning, she thought this would mean, oh, individuals were short-term placed on their stomach or their side, but she said, in fact, when inquiring further, individuals were placed sometimes 10 or more hours at a time in a prone position, and then often seeing upper extremity and lower extremity peripheral nerve compression injuries. And so Naga is wondering, is that an anterior horn cell viral effect? Yes, I obviously couldn't speak to that, but these are definitely all good questions. That are these things affecting the virus, and was it just a coincidence that it was also, she was seeing these proning in these individuals? I definitely don't know the answer to that. And I touched on a bit, how can we explain the variability in the incidence of these neurologic events? It seems like everyone in all these studies is defining it slightly differently. Are you including skeletal muscle injury? Are they including I think some studies include headaches in terms of neurologic symptoms. So there's a very wide disparity in terms of how neurological events are being defined, helping to explain why we're seeing 6% in some and 65% in others in terms of the incidence of events. Okay. So there was an interesting reader response in Neurology that a doctor and professor at NYU in neurology was stating, basically, be careful because this could be another case of measles and a broken leg. And so, Steph, I'll have you go ahead and advance. And basically what he's asking us to watch out for is that correlation does not equal causation. So, the amount of ice cream sold and shark attacks are correlated, highly correlated in the month of July, but this does not mean that ice cream causes shark attacks. And so his warning, his short response is basically that, an individual that comes into the ER who is having a stroke and then is tested and tests positive for coronavirus, that we shouldn't make the assumption that coronavirus is causing that stroke. It might be an incidental correlation, and correlation does not equal causation. So I'm sure you've heard that all the time. I know I hear that all the time in my education, but it's easy to fall into that trap. I know I easily can fall into it. So we all need to be aware of just because these two things are both present doesn't mean causation, and we need to learn a lot more about how the virus is interacting with the neurologic symptom before we can understand causation.
I think that that's a good point. Obviously, it's always good to keep in mind correlation doesn't equal causation. But then I would relate it back to this increased incidence of not only are we talking about, let's say, cerebrovascular disease, but also, DVTs and PEs. So is it a result of the neurologic system being impaired, or is it actually just the cause potentially is just the coagulation within the blood? That would be something that would be, that I would think about with this point of correlation doesn't equal causation. And also, you have all these critically ill patients that are stuck in the ICU on ventilators. We already know that post ICU syndrome is very prevalent and can cause a lot of these same problems. So is it a result of coronavirus, or is it just a result of the fact that they're on a ventilator?
Absolutely, Steph. There is so much to discertain and try to pick out in understanding kind of the causal effect here and the causal chain and what is mediating and moderating these relationships. Right, this article is just scratching the surface and isn't helping us to answer some of these more specific questions about how coronavirus is related to our neurologic system. But yes, these are all great questions that hopefully will become uncovered as we are able to gather more data and do more research. So their discussion for this article is that patients with underlying neurologic impairment are vulnerable to more severe illness when infected with COVID-19. So this is something for us as therapists to keep in mind when we're seeing that an individual has that diagnosis of a neurological disease. Maybe we are enhancing our education to ensure that they are educated about how to minimize their risk with physical distancing, hygiene, mask wearing, as well as supporting their general immune function. And then there's this trend towards patients with pre-existing cerebrovascular disease having a higher risk of ICU admission, as well as overall mortality. So it seems like cerebrovascular disease should be one of those red flags that if we're seeing that in our patients, we are understanding that they are even at a higher risk than the general population. And what can we do as physical therapists to affect that? We see that COVID-19 has this variable rate of incidence of secondary neurological events. And then this comes back, Steph, this next point comes back to what you mentioned. Is it whether the trend towards worse outcomes is related to vulnerability from neurologic disorders, or is it the presence of other cardiovascular comorbidities that's leading to neurologic complications in these patients? So it's a bit of the chicken and the egg. We don't know which is coming first. And then finally, I've mentioned this last bullet before, but we don't know if the virus itself is attacking and infecting our nervous system directly. It seems like what we're gathering that it's more of the previous point, that it's related to these cardiovascular or vascular or cerebrovascular comorbidities that are then combined with COVID, leading to insults to our central nervous system and peripheral nervous system potentially. So again, this has me thinking, and I'll have you advance it twice, where do we go from here? And what are our research questions specific to physical therapy, and how do we take this information and bring it into practice? What can we bring to our practice knowing this information? So does anyone have any thoughts, questions, ideas that they would like to share in terms of how do we bring this information into the clinic? Feel free to use the chat or to unmute yourself.
I think it'd be interesting, I'm in outpatient physical therapy. I think that it'd be interesting to see, once all this is over, what patients are going to look like coming in for outpatient physical therapy or even home health physical therapy. What is it going to look like in the community? Are we going to be treating them for both, the respiratory part of the illness, and are we going to be also adding in some type of doing some like neurological type physical therapy. I'm also really interested in how this is going to affect their balance and their risk for falling.
Absolutely, Steph. It seems like it's that trifecta, right? So if their neurologic system is impaired, as well as a deconditioning from post-ICU syndrome, how is that all going to affect their fall risk in terms of weakness, neurological system impairment, and then being sedentary, so that lack of physical activity, all kind of having an effect on their potential fall risk. And Naga wrote in neurotropic virus infections as the cause of immediate and delayed neuropathology. Aha, oh, he's sharing an article. So, okay, so I don't know this article, Naga. I'm assuming you just did a quick search, or are you familiar with this one? And is this specific to coronavirus or other viral infections? Supporting your slide, right, okay. Oh, I understand what you're saying that maybe these infections are causing neuropathology themselves, that the individuals that are seeing some of these nerve injuries, peripheral nerve injuries. Excellent, okay. So, right, so I mean, I think that, and Steph, I know you're talking about individuals who have had COVID. I'm also wondering those individuals who are going to start to come out as the state starts to reopen, and they're coming into our clinics, and maybe they've been more sedentary. Maybe they do have Parkinson's disease or MS or spinal cord injuries or other sorts of comorbidities, and they're now coming out. What is our role actually in minimizing their risk for contracting COVID moving forward? And so that brings me to my next slide, and go ahead. Yep. So, you know, I'm not the only one wondering about this. Jimenez and Pavone put out an article where they are suggesting, as well as another article by Fallon et al., and I have the reference at the end, saying that, you know, we know about the power of exercise and physical activity. We know that it enhances the circulatory system. We know that it enhances the respiratory system, as well as the skeletal system, nervous system, muscular system. And we know that it even enhances, when done at moderate intensity, immune function. So we know that it's generally good for all of these systems that are potentially being affected by COVID. We also know that exercise decreases the risk for all of these other comorbidities that put you at higher risk for complications with COVID. So diabetes, hypertension, right? Cardiovascular disease, cerebrovascular disease, respiratory problems. So, you know, some are proposing that exercise and exercise prescription can serve as a preconditioning to either hopefully prevent contraction of COVID-19 in order to boost our immune function, or even to allow individuals to have less of a severe response. So what I would love to see going forward is, could we get those individuals with cerebrovascular disease that have not contracted COVID-19 and provide them with preconditioning with exercise, with adequately dosed and prescribed moderate intensity exercise, to enhance their immune function, to enhance their circulatory system, respiratory system, and maybe prevent them from getting the disease or minimizing the effects of the disease. So I think that that is a huge role that we can play in this whole pandemic. So I'm wondering what others think about that. Yes, Naga, I am familiar with that article. By Hall et al. That was one that I did read in preparation. So yeah, they're basically saying, right, so exercise decreases sedentary behavior, absolutely, and everyone is advocating for it. Another interesting finding, I believe it was the Jimenez and Pavone article. So in the Parkinson's area, which is the area that I specialize in, we are often advocating for high intensity exercise. I know this is also a trend in stroke rehabilitation, in a lot of the neurologic rehabilitation. And so these authors were actually proposing that during this time period, maybe we scale back on intensity because there's evidence that at high intensity, this could actually reduce immune function, that instead we focus upon moderate intensity exercise, which has been validated to improve immune function, if our goal is right now to minimize risk and support, and minimize the severe response to coronavirus. So I really appreciated these perspectives that we have a large role in terms of ensuring, not just the people who are recovering from COVID, but in elevating the health of society in general, to try to prevent the onset of COVID.
Yeah, I think that's a really interesting point, Cristina. I know that, in our profession, we've been trying to talk more about population health and move more toward prevention. And I mean, especially since there's still no vaccine for this disorder. I mean, think about the power that, again, I'm speaking from a private practice perspective, but even marketing something like this could be for a patient population, especially those patients who are they're terrified to go outside still.
Absolutely, absolutely. And so it could even be having your physical therapist, a healthcare professional on board who is able to adequately and safely prescribe you exercise that's not going to overdo it, not going to underdo it, but target your individual needs, and potentially maximize your health and immune function. I think is definitely an approach that we need to advocate for in our role in this pandemic. We know that exercise is powerful, and I know I'm preaching to the choir when I say it's underutilized in our healthcare system, because it really is that magic pill that it has so much power in our health. And recently in the House of Delegates, we were presenting that physical therapists have a role in sleep health and nutrition health. So, a physical therapist is not only going to talk to you about your physical activity, but making sure that you are addressing all of these systems to maximize your health and potentially make that referral to a nutritionist or to a sleep health professional, or if you're having mental health effects, as we've seen in the literature coming out, individuals dealing with depression and anxiety while being in quarantine. So can we address that through exercise and physical activity, and or refer to a mental health professional? So I think we do have an important role to play in managing this virus moving forward. Any other thoughts or ideas on how we can bring this evidence in this article into practice? So physical therapist is a gatekeeper in long-term rehab. Absolutely, that we're not just that one-term, one episode of care, healthcare professional, but we are there as a long-term partner in that individual's health, and this can definitely be a part of it. So I've listed some of the references here, and then I just wanted to also share with the group that we have 2 more journal clubs upcoming, next Tuesday and the following Tuesday. So next Tuesday is blood flow restriction resistance exercise for older adults with NEOA. And then the following Tuesday is exercise guidelines for cancer survivors. So thank you all so much for joining. If you have any additional questions, please ask them now, either in the chat or with your mic. We can keep our conversation going, and if not, we can end it there.
Well, thank you so much, Cristina, for a very informative topic. And thank you guys for joining us tonight. Hopefully you'll join us again next week. I know Regine was just logged in just a little bit earlier here, so she'll be presenting next week. So hopefully you guys will be able to join us for that. Otherwise, if you guys don't have any other questions, we'll see you all next week. Thanks for joining us again.
Thanks, everyone. Bye-bye.